Hello, good morning. My name is Christos Kontovounisios. I'm a colorectal surgeon with an interest in cancer and complex pelvic exenteration. I'm an academic surgeon working at Imperial College, and I'm affiliated to the Chelsea Westminster and the Royal Marsden Hospital. Today's topic is on the diverticular disease, and I will try to give you an overview of the frequency, the prevalence of this problem, and how we can manage this either with a conservative approach or some surgical options that we have on everyday practice. I think when we talk about diverticula, it's very important to maybe understand a little bit on the definitions of these terms, which are medical terms, but they are quite common in everyday practice. So a diverticulum, it's like a protrusion, it's like a sac that can be on the outer layer of the bowel wall. If you have many diverticula, which don't cause any problems, then this is what we call diverticulosis. So you can live with diverticula without having any problems. And it can happen either through images or through, for example, a colonoscopy or endoscopy. We know that they exist, but they don't cause problems. But when there is an inflammation or another complication related to a diverticula, such as bleeding, then we can use the term diverticulitis, which means inflammation of the pockets. So this problem or this condition or this disease, it wasn't common 100 years ago. And we know that with time, the prevalence has increased, and it also has a different presence in different ages. So it's not so common in young age, but it's quite common at above the age of 60 or 85. And there is a gender prevalence as well, and depending on different age groups. But the rationale is that it is very much dependent on the diet. There is no strong evidence that there is a genetic predisposition. It's very much dependent on diet, and that's why I'll give you some examples later on differences between different continents and different countries. Now, what actually happens, if you see on the picture, is that there's a pocket on the outer layer of the bowel wall. We know that on the bowel wall, there are some weak points, and weak points is where arteries can pierce through the bowel wall and supply with blood the different layers of the bowel wall. And when the pressure inside the bowel, either because of straining or constipation or slow transit, so it takes quite a long time for the feces to travel from one side to the other side, the pressure builds up, then through these weak points, the inner lining of the bowel finds its way and creates an out pouch on the outer layer. This is another picture of how the pockets may look like. And the problem with these pockets is that the wall of these outpouts is very thin. And because it's thin, it can burst. And this is when the problem starts. So as I said, this problem, it's more common in the Western nations. And that's why the concept of the lack of fibers, which is quite common a few years ago or a few decades ago in the Western nations, is possibly the reason. Lack of fibers means more a chance of constipation, which increases the pressure inside the colon, inside the bowel, and it can lead to the presence of diverticula. If you see other continents such as Asia and Africa, the prevalence is very low, which again fits with a theory of the lack of fibers in our diet. So we know now that low fiber can lead to diverticular disease. It's not proven, but it's strongly suggested. The Western diet is low in fiber and leads to diverticulosis, while other countries don't have this problem. Obesity is associated with diverticulosis, and especially in men above the age of 40, and obviously lack of physical activity. The most common signs and symptoms of diverticulosis are diarrhea, can be constipation. So essentially you may have good and bad days or changes on your bowel habits. You may have heartburn and flatulence, or sometimes you may have no symptoms at all. If you remember, diverticulosis doesn't necessarily mean there is a problem. It just means that there are diverticula in the bowel. This is how diverticula look like. So this is from a colonoscopy where we see the bowel wall from inside, and you can see it's like a small cave that protrudes outside and creates this outpouching. If you see on the right-hand side, there is no redness around those pockets, so there's no associated inflammation. This is what diverticulosis, it's called uncomplicated diverticulosis. This is another picture using a contrast dye and an X-ray, and you can see where the arrows are, these pouches again. And this is with the use of a CT scan, which is the gold standard and the way we can diagnose how severe the diverticulosis can be, or the presence of inflammation, diverticulitis. So we consider the diverticulosis as an asymptomatic condition, but it can cause problems. And to avoid those problems, if we know that the diverticula exists, we have to be proactive. And how can we be proactive? Is by changing the lifestyle, increasing the fluid intake, increase the fiber intake, and make sure that we exercise on a daily basis. The problems start when the presence of the diverticula become complicated. What does this mean? Inflammation. It means bleeding, and it can be up to 25% of the patients that they have the diverticula. And the most common signs are pain in the left side of the abdomen, where the majority of the diverticula are, fever, and on a blood test, you will see raised inflammatory markers. These are the three common signs and symptoms that can raise the suspicion of diverticulitis. We can also have cramps, or we can have blood in the stool, because as these pockets burst, then the small blood vessels can cause bleeding. So if someone has lower abdominal pain, fever, shivering, and on a blood test there are raised inflammatory markers, there's a strong suspicion of inflammation in the bowel from diverticulitis. And this is the classic history, what we teach our students, how to diagnose someone with diverticulitis. The pain can vary depending on the presence of the diverticula and the inflammation. The pain ends up becoming constant, it's not colicky. And the fever is almost, will become a problem in almost all the cases as the inflammation progresses. Now, it can be that we have previous episodes of pain without fever. So sometimes we do get early signs, but we don't really pay attention. But we should always think, if we are constipated, there's a change in our bowel habits, and there are on and off pains in the lower abdomen, it means that that should raise the suspicion that something is wrong with the colon and the bowel. And this is what we quote in terms of the different symptoms. But I would say that it's the pain and the fever which are the two symptoms that should make a patient to go and seek an advice, either with a general practitioner or to a colorectal surgeon. So when we examine someone, there will be sometimes a palpable mass in the lower abdomen. It might be very tender and painful. And sometimes you may have pain on the other side, on the right side, on the upper abdomen, if there is a lot of inflammation and fluid in the tummy. Sometimes patients can be in agony and cannot even breathe properly because of the pain. This is when we have generalized peritonitis. These are the extreme scenarios where patients need an immediate operation within a few hours. On the blood test, you will have increased inflammatory markers, but it could be that if it is a very early sign, you don't have massive changes. This is an example of inflammation. So if you see around where the arrows are, there's a lot of cloudness around the white contrast inside the colon. That means inflammation around the bowel. This is how diverticulitis look. And this is on another example where you can see loculus of gas. These are what the two arrows demonstrate. So it means that the pocket had burst, and then air, gas from inside the bowel had escaped outside the bowel. And this is, again, a quite a serious problem, because it means that there will be contamination outside the bowel and the patient will be quite unwell. This is, again, another example of different pockets of gas outside the bowel. So how do we treat the diverticulitis, the inflammation? The first thing to do is we need to rest the bowel. We are not supposed to continue the eating and normal eating and drinking, because the bowel then will keep moving and keep causing more problems. So we need to completely rest the bowel. That means that we can stay on fluids only. And sometimes even this is not the case, therefore patients have to have intravenous fluid to supplement their needs. We have to start antibiotics, and what we commonly do, there are broad spectrum antibiotics that can cover most of the attacks of diverticulitis. The most common is a combination of ciprofloxacin and metronidazole, or other combinations of other antibiotics. We need to monitor the patient very closely, because things can change within 24 hours or even 48 hours. And if the symptoms fail to improve, then a surgeon, a colorectal surgeon, has to be involved. If everything settles down and there's no need for an operation, what is very essential is to have a colonoscopy, to offer a colonoscopy to our patients 6 weeks after the initial attack of the diverticulitis. And the reason is there's always a risk within that area of the inflammation to have another cause that has led to this picture that you see on a CT scan, such as cancer. Cancer is not associated with diverticulitis, but you may have a polyp which may have cancer cells where the diverticula are. So if you imagine that we make the diagnosis of diverticulitis with a CT scan and we see the bowel from outside, it's very important to estimate and visualize the same problem when the inflammation settles down from inside the bowel, to inspect the inner lining of the bowel. And that's why we offer a colonoscopy 6 weeks, because this is what the time, this is how much time the bowel needs to completely heal. Sometimes if the problem is quite low, it's close to the pelvis, a flexible sigmoidoscopy can be an option. And as I said, this is to exclude the presence of cancer and also to have a baseline of how extensive the diverticula are in the bowel. Another common complication of diverticulitis is the formation of an abscess. Abscess, imagine it's a pocket of fluid, of pus, that can develop next to where the pockets are. So imagine that there is an ongoing contamination through a small pinhole in the bowel, and that can occur in about 15 to 16% of the patients with acute diverticulitis. There are different ways to treat this. Sometimes antibiotics can be one, but sometimes you need to try to drain that abscess to give an escape route for that fluid to come out. And that's why we use a CT-guided drainage, where we can insert small catheters where the abscess has formed and allow the fluid to come out. This is done by specialized interventional radiologists, and sometimes we need to leave that drain for a long period of time, but this way you avoid an operation, which will mean to remove part of the bowel. Now, this is an example of how an abscess can become even a bigger problem, which leads to what we call fistulas. Fistula is a communication between two organs. So let's say you have, in female patients, you have next to the colon, next to the bowel, you have the the vagina, the uterus, or the bladder. In a male patient, you will have mainly the bladder and the small bowel in both males and females. And if there is an abscess, which it happens to develop next between the bladder, let's say, and the colon, then patients may have symptoms, urinary symptoms more often. And the reason is the contamination will go from the bowel to the abscess and will find its way to the bladder, and patients may have dysuria or pain or burning, or what we call pneumaturia, where there is gas coming when we urinate. The same can happen with the vagina or the uterus or other organs such as the small bowel. This is quite challenging when it comes to try to treat and manage these patients, because it requires big operations with can lead to the need to have a diversion of how the feces come out with the formation of a stoma, which is not permanent, but it is temporary. This is the major types of different fistulas, I said, that we can see in patients. And these are the main symptoms that I've explained, depending on which organ is affected. So surgery is the option when we have such a complication, which is the fistula, and that is to remove the part of the bowel which is affected, that has the inflammation and the abscess and the fistula. And then we need to find the other end of that tunnel to the other organ and try to close that defect from the communication. And if it is, let's say, the bladder, sometimes you have patients have to have a catheter that has to stay for a few days. The surgical approach to diverticulitis is what we call the two-stage procedure. This is the most common practice, which means to remove the affected part of the bowel, but you cannot join the bowel again together. If you try to make an anastomosis, a joint between the two ends of the bowel on the presence of inflammation, that joint will not be successful. There is a very high risk of that joint to break down. That's why we divert by creating a stoma where the bowel has to come to the skin and the feces are coming on a stoma bag. And minimum 3 months later, sometimes even longer, the patients will require another operation where you can join the two ends together. The second most common cause of the presence of diverticula is bleeding. So many patients may present with bleeding, what we call hematochezia, which means presence of blood in the feces. And it can be a really serious problem. And if you remember the diagram in the beginning, it's those small blood vessels that they burst and then they start bleeding. You also have usually elderly patients that they have medications with blood thinners for different regions, and that can it can complicate the bleeding even more. The majority of these bleeders, the majority of these bleeding points, they stop. It takes some time, they stop. Patients might need support either with blood products or with fluids or by resting the bowel, but they stop. But there is sometimes a case where the bleeding doesn't stop and we have to intervene. There's a risk of rebleeding if we already have had a bleeding, and this is up to 21 to 50%. And this is how, if you see on the right-hand side, a diverticulum, how, if you imagine these are the blood vessels that they burst from the pressure and then they start bleeding. The main obviously sign is the presence of blood in the stool, and you don't necessarily have pain and bloating and fever. It could be just bleeding. So as I said, the management is resuscitation. We perform images to localize where the problem is. We support the patients if needed with blood products. And if we have to, we can use, again, with the CT as a guidance, and with the expertise of interventional radiologists, we can embolize, we can find these bleeding points and stop them with the use of a CT scanner and the expertise of specialized radiologists. Sometimes you can use endoscopic approach where you find that cave, you find that area, and then you can stop, you can cauterize, you use energy devices to stop a single bleeding point where the blood is coming from. There are also different sophisticated techniques if the CT scan fails to identify where the bleeding is, where we have good sensitivities and specificities to localize if we have to operate, so we know which part of the bowel we have to remove. Because imagine if there is a true emergency where there is bleeding, but you don't know, you can't just remove all the bowel. So it's very important to localize where you have to operate. If this becomes a surgical emergency, you have different options. Sometimes you remove part of the bowel, and again, you cannot join. You have to do the two-stage approach where the patients have stoma. Sometimes you can't join. It depends on the patient's background, medical problems, or other surgical problems, but the morbidity is high. So this is a summary of different signs, symptoms, and possible complications that someone might face with diverticula. Thank you very much.